Thank you. Well, good afternoon, everyone. I hope everyone's been enjoying the conference, and thank you for joining us for our last session of the afternoon with our keynote and closing speaker, Dr. David Burns. Dr. Burns is an associate professor at the University of Toronto at the Faculty of Social Work, and he holds a Canada Research Chair on preventing the mistreatment of older adults. Dr. Burns has completed a PhD at Columbia University at the School of Social Work in New York City, concentrating in gerontology and advanced practice. His program of research focuses on issues related to elder abuse and ageism, including the development of basic science and interventions to prevent the mistreatment of older adults. He has advised major international organizations on these topics, such as the World Health Organization and the National Institutes of Health. He also advises different levels of government and nonprofit organizations, such as Level Adult Protection Services, on the development, implementation of older adult support programs and preventative strategies. It is my pleasure and my honor to introduce Dr. David Burns as our closing keynote speaker. Thank you so much, Dr. Burns.
Thank you very much, Mary. I really appreciate that kind introduction. I really appreciate the invitation to speak as well from Elder Abuse Prevention Ontario. I really enjoy these conferences, and you know, it looked like an excellent panel of speakers today and topics that were covered. So certainly appreciate all of the efforts of Elder Abuse Prevention Ontario and for the invitation. So I'm going to start off here. The topic of this talk is about RISE, which is a community-based elder abuse response program intervention that myself and a couple of colleagues developed. So I'm going to walk you through the sort of the background and the rationale for RISE, its development, some of the kind of conceptual or theoretical frameworks that guided the development of RISE. I'll talk about the model itself. I'll go over some evaluation findings that we've been working on over the last few years, and then talk about some next steps with implementing RISE in Toronto. Okay, so I'll start off just sort of a bit of a background, and I know probably a lot of you are aware of some of this, but just briefly, in Canada, we've found over the last few years that using population-based data, that approximately 8 to 10% of older adults who live in the community become victims of some form of elder mistreatment. Okay, so it's about 1 out of every 10 older adults, which actually translates into some pretty huge numbers, as you can see here. And I've been involved in some of this research, and I can tell you that you know, there's actually reason to believe that this may be an underestimation, because often these surveys, the survey-based research, it excludes, for example, older adults with cognitive impairment or those who live in institutional settings, who obviously represent vulnerable subgroups of older adults. So this is a huge, huge problem, and you know, certainly it's gaining more and more recognition and getting more and more attention. I also just want to point, as we kind of come into the province here of Ontario, we're actually at a fairly significant historical period of time in our province. So if you see down here, this sort of blue line represents the proportion of the population who are children, and this kind of greenish line represents the proportion of the population who are older adults, or age 65 and older. And we see here that in and around 2016, 2017, it was the first time in the history of our province that the proportion of older adults actually overtook those who are children. And we sort of currently find ourselves sort of in this area here. So it's a very, very, I would say, important time in our province as it relates to our age demographics. And, you know, it carries significant implications to the issue of elder abuse. Specifically, in the absence of sort of effective prevention interventions, it means that the absolute number or kind of the sort of the scope of this problem is going to keep getting bigger and bigger and bigger in proportion with the expansion of older adults in our population. What I mean by this is that if, again, in the absence of effective interventions and preventions, that prevalence, that 1-year prevalence rate, we can assume that will remain constant. And, and 10% of 2 million is smaller than 10% of 4 million. Unfortunately, our knowledge and our understanding of what are effective elder abuse interventions, it represents the largest gap in the field. The field's come a long way in terms of understanding the prevalence, the risk factors, and a lot of other really important aspects of this issue. But when it comes to actually developing and testing sort of evidence-based interventions, it represents our sort of largest gap in the field. And there's been many systematic reviews on this topic to kind of identify evidence-based interventions, and they all kind of come up with the same conclusion, that we have no evidence-based interventions to address this growing problem. Not just here in Canada, but throughout the world. I can say that this is something that is becoming sort of drawing more and more attention. I'm currently involved with a group with the World Health Organization, and we are starting what we're calling an intervention accelerator. So recognizing this major gap in the field, and sort of over the next 5 years, identifying and helping to evaluate and scale promising interventions. Okay, so let's kind of dive into RISE. So we developed RISE to try to kind of address this gap. And I'm not going to go into a ton of detail because but I will say that the development of RISE was based on a lot of different kind of forms of groundwork. So it was based on prior research on that I had done on goal attainment scaling, which kind of identified a need for expanded kind of interventions with cases of elder abuse, for example, that could involve the perpetrator as well. This started in the U.S. and we did extensive consultations with Adult Protective Services caseworkers and supervisors to understand what kind of was needed. We conducted reviews of the literature and sort of relevant theories, and we sort of developed this model by bringing together core intervention components or modalities that have shown evidence in other domains of family or interpersonal violence, like child maltreatment, intimate partner violence, domestic partner violence, or that have shown promising results in the field of elder mistreatment. And so I'll start off just by kind of giving a bit of an overview of some of the theory that has guided kind of the development of RISE and our practice. So the first is taking this kind of ecological systems perspective, and basically what this means is that it sort of recognizes that elder mistreatment is a very complex issue, as many of you know, and to really sort of address this issue and work with cases in sort of in the effective, encompassing manner. Obviously, it's important to work directly with the victim, but it's so I'm just gonna put some of these things on my screen. But we also have to work with the perpetrator. This is a relationship level issue, and so it's important to work with both the victim, the perpetrator, as well as working with them at the level of their relationship, and then, if possible, working with sort of those systems that surround them, like the family system, the home environment, their social support systems, as well as larger social determinants of health. So this really kind of guided the development of what RISE ends up looking like. And then we get into this sort of it's guided, very much guided by a client-centered perspective. So if we were kind of developing an intervention for some other issue, let's say like, working on depression among youth or something, it is possible that we could develop a fairly standardized intervention model that kind of takes a step-by-step sort of manualized approach to the intervention that has a fairly well-defined presenting kind of problem, and sort of we would replicate this sort of manualized approach to intervention across cases. And this is sort of an ideal way to approach intervention development. You might think of like a manualized CBT approach or something like that. But for those of us who work in this area of elder mistreatment response programs, we know that this is just not possible. That as we look across cases, the trajectory of change is very different across cases. It's not like this scenario where we can kind of there's sort of an expected sort of trajectory of change. With cases of elder mistreatment, they're very, very different. To begin with, the way that the problem is defined varies considerably across cases because it includes, multiple subtypes of elder mistreatment. It also, considers that victims themselves perceive the problem differently across cases. In some cases, they go sideways. In some cases, they go backwards. And this is all part of like the reality of working with elder mistreatment cases. And that's not to say that some cases don't have similar needs, but we very much have to take a client-centered approach in this work. And just by the way, when I'm talking about an elder mistreatment response program, what I'm referring to is an intervention that responds to suspected or cases of mistreatment. I'm not talking about primary prevention where we're trying to sort of prevent the problem in the first place. Again, just kind of getting at this whole kind of client-centered sort of approach. If we were looking at some other issue, it is possible, for example, that when we're defining like, what does success look like for an intervention? It's, like if we were just thinking something like depression, it's possible that we could define success similarly across cases and even use something like, the Beck depression inventory, so, some kind of standardized scale across each case. Again, when we're working with cases of elder mistreatment, we sort of have to operate within this kind of practice paradigm that sort of assumes that like what we refer to as multifarious case outcomes. It means that success is defined differently across cases, and we have to sit comfortably with that. And in many cases, success, through sort of a harm reduction kind of lens, we have to be okay that respecting the kind of self-determination and autonomy of older adults, that they may not actually want to completely stop kind of the risk of re-victimization. They may, in many cases, want to maintain a relationship with their perpetrator, even continue living with them. The other thing that informed kind of the development of RISE is this acknowledgement that arguably one of the largest challenges in working with cases is engagement, client engagement. So we know that the vast majority of victims of elder mistreatment who live in the community never come into contact with the formal support system. In fact, population-based research that I've been involved in has showed that only about 15% of victims ever come into contact with some kind of formal response system. And so the vast majority of victims are sort of out there enduring this problem kind of in isolation. It's possible that they have informal supports, but at least as it relates to seeking formal support, most of them are sort of isolated. We also know that even those older adults who do come into contact with formal support systems, that many of them kind of refuse services to begin with, and those who do accept services, many of them then drop out of services. So this whole issue of engagement is a major sort of barrier that needs to be considered and overcome in any kind of intervention that's working with cases of elder mistreatment. Some of the qualitative research that we've done with victims of elder mistreatment to try to understand, like, why is it that it's so difficult to kind of come forward and receive help, engage with formal support services, and so we've interviewed elder abuse victims about this, and some of the common responses, that again you may expect, but this comes from them themselves, is considerable feelings of shame and guilt and embarrassment, a sense of stigma and distrust about becoming involved in public systems, particularly among subgroups of older adults who've experienced oppression and marginalization, fears about what might happen to themselves. For example, am I going to get placed in a nursing home? Am I going to sort of lose my primary caregiver who may also be a perpetrator? And a big one that comes out of this is fears about what's going to happen to this, to my perpetrator, like my son, my grandchild, my spouse, my caregiver. Are they going to become involved in the criminal justice system? Are they going to kind of become homeless? All these things. And then another big one is prioritizing family relationships and kind of family reputation over the needs of one's kind of self and one's safety. So all of this kind of helps us arrive at this kind of conclusion that again, kind of it's really important to think carefully about how do we engage older adults into our services and kind of develop kind of trusting client practitioner relationships, and certainly that is something that's shown to be a serious predictor of success in other social service domains. So this brings us to the RISE model, and this is kind of like a diagram of the model, and I'll give a bit more detail in a second. But you can see here that RISE, the acronym, stands for a couple of different things. If you look at these circles here, and the first letter of each circle, so on one level, RISE represents our approach in working with cases at the relationship level. So we work with at the level of the victim-perpetrator relationship. We also work with them each as individuals. A huge part of RISE is to sort of strengthen the formal and informal support systems that surround the victim and the perpetrator. And then we also work in partnership with larger systems within the context of the response system. So the core kind of intervention modalities or components that we use in RISE, I'm actually going to start with some motivational interviewing. And so this is something that's shown evidence in other domains of family violence. And the idea here, for those of you who aren't familiar with motivational interviewing, is that it's used when you're working with clients or populations who experience ambivalence about making change. And we know this to be true with victims of elder mistreatment, that they're often reluctant, not eager to kind of, as I mentioned before, engage in services, but also make change. So motivational interviewing helps kind of us kind of open up the possibility of change. When we're working with victims and perpetrators at the level of their relationship, we use restorative justice approaches. And so, again, for those of you who aren't familiar with restorative justice approaches, the idea is to repair harm in the relationship while holding the perpetrator accountable. Teaming is a technique that we have borrowed and adapted from the child welfare system. So the idea behind teaming is that in each case, we call them advocates, but essentially the RISE caseworkers or the advocates who implement the intervention, they generate a team of both informal and formal supports that surround the victim and perpetrator, who take sort of a collective sort of responsibility to work with them as a support network to prevent this from happening again. And this team, the idea is that this team actually lasts beyond the time that the case is formally closed with RISE. And so, just an example, and the composition of the team completely depends on the needs of the case. So it may include, for example, a neighbor who agrees to visit the older adult once a week, or it may include somebody from their faith-based organization who agrees to bring the older adult to service once a week. It may include somebody from the bank, or it may include somebody from law enforcement, or somebody from a healthcare team. It really just depends on the needs of the case. And then finally, we use supported decision making with older, in cases in which an older adult lacks some level of capacity. And then we incorporate engagement principles. Our advocates are trained in client-centered engagement practices, and then we use goal attainment scaling to kind of track change across cases. So, we know that formal goal setting is an effective way to facilitate behavioral change, and goal attainment scaling is a very client-centered way to kind of establish goals and track change across those goals. As I mentioned before, we tried to develop RISE to really try to address a gap in the service system. And so I'm going to start off with what that looks like in the US, and then transition over to what that looks like in some parts of Canada, including Toronto, where I work. So in the US, they do have an adult protective service system. And so that's kind of like a counterpart to what we know as like CAS. So it's a centralized state or county level administered program that essentially, they're there to intake referrals, conduct an investigation. They use the terminology investigation, and then, arrive at some kind of substantiation decision. But it turns out that APS, for the most part, does not actually have like an actual intervention phase where they work with cases and support those cases. And so that's where, in the US, that's where the kind of RISE came into play, is because to kind of address this gap around having an actual intervention phase. In Toronto and many parts of Canada, we don't have an adult protective service system. And so, the way RISE is sort of conceptualized as working here is that we would receive referrals from all sorts of places, whether that's law enforcement or health professionals, or concerned others, meaning family members or friends of older adults, other social service programs that work with older adults, the legal system. And so RISE would actually be doing that sort of intake and initial assessment phase, as well as providing the intervention work. So I'm going to kind of go back to our work in Maine, which is where this started. So to date, we've worked with over 450 cases since 2019. The average age of our clients is 75 years old, mostly women, 60-40% to men. We started off in 2 counties of Maine, and have since scaled throughout the entire state. We have sort of a sort of overarching operations director. We have, as well as sort of overarching supervisor, 3 team leaders, and then 9 advocates, which again is sort of what we call sort of for caseworkers. The average case load across advocates is about 20 to 25 cases, and we work in both rural and urban settings. So I'm going to walk through now some of our findings, our evaluation findings. So we kind of divide this up into different categories: so feasibility, acceptability, and improvement on certain outcomes. So in terms of feasibility, we have found that it's worked well. So only about 6% of clients who are referred to RISE from APS. So we have partnered with Maine Adult Protective Services, who, as I said before, they kind of, in that context, receive intakes, do an investigation, arrive at a substantiation decision, and then they refer us, clients to do sort of the intervention work. And only about 6% of clients referred to RISE decline services upfront. And then among those clients who do accept services, about 4.5% drop out prematurely. So this sort of demonstrated strong feasibility indicators. In terms of acceptability, we surveyed active clients around their kind of program kind of satisfaction with RISE. About 76% reported that the program had met most or almost all of their needs. About 89% said that reported being mostly or very satisfied with the program. And about 78% said that they would definitely come back to the program if they needed help again. And then I would say our key kind of outcome finding to date is around recidivism or kind of case reopening. So what we've done is we compared cases that were exposed to adult protective services only, so sort of like usual care adult protective services, and we compared those cases to those who'd been exposed to both APS and RISE, kind of that partnership. And what we found that, first of all, we found that the cases that were being referred to RISE were more complex in that they had a longer history of involvement with APS. But adjusting for that fact, what we have found is that cases who have been exposed to RISE show a significantly lower likelihood of re-referral back into the system compared to those who did not receive RISE services. And so that was an important finding in Maine, in terms of scaling it. And actually, we recently found out that RISE has been written into the annual state budget. So it's got, so it now has sustainability there, which is really exciting to find out. And then some other outcomes that we surveyed active clients about. So this is sort of just a summary or a list of outcomes that the proportion of clients who said that these outcomes changed either somewhat or a lot better since starting their work with RISE. We asked them about things like personal stress, personal worry, quality of life, self-efficacy, knowledge about informal and formal supports, and as well as stuff about their working relationship with their advocate. Again, acknowledging that's a very important part of the process. I might keep going here because I don't want to spend too much time on this. We've conducted qualitative interviews with the APS practitioners with whom we have sort of partnered to kind of really understand their perspective on working with us and working with RISE. Both, what are strengths and what are things that can improve. So a lot of this I think I've already sort of mentioned, but certainly the opportunity to engage in longer term support, the flexibility to work with both sub-threshold cases as well as those cases who kind of meet substantiation criteria. And that's sort of an important part of RISE is that, we do want to work also with those cases that, maybe they don't meet completely the threshold of a substantiated case, but they do show indications of risk that, if not addressed, could sort of elevate and escalate. So these are anyway some of the qualitative findings. And then I'm just going to talk a little bit about next steps, and then I'm happy to open it up for questions. So some of the next steps, based on the work that we've done in Maine, we have received funding from the Public Health Agency of Canada, who I'm very, very much appreciative of and want to certainly acknowledge here, to adapt, implement, and evaluate RISE in Toronto. And we're doing this in partnership with Elder Abuse Prevention Ontario. And over the course of this 3-year project, it will be administered out of our faculty. And we're going to be hiring 1 RISE supervisor and 2 RISE advocates. So it's sort of starting at that level. Currently, literally in the process of hiring right now. And if any of you have, would like to kind of share links for job postings, please let me know. So this is very exciting, and the idea is over the next 3 years to implement and evaluate RISE in the context of a randomized control trial. We are also we received funding recently to implement RISE in New Hampshire, and specifically to test whether like sort of an added component related specifically to working with cases involving older adults or perpetrators with substance use issues. So in this particular project, advocates will receive, or some advocates will receive, additional training around substance use issues to see if that additional training component arrives at better outcomes for cases that involve substance use issues. And then we also are working in Seattle with the district attorney's office. So given sort of our emphasis on restorative justice, we're working with them as like a diversion program, essentially, as an alternative to the criminal justice system for certain cases in which that's appropriate, are referred to RISE as an alternative to the criminal justice system. And those are some of our next steps and what we're currently working on. Is just a few references that I had included in the presentation. And I'm happy to open it up for questions at this point. Thank you very much.
Thank you. That is wonderful information, Dr. Burns. Thank you so much. Quite a few comments again in the chat box saying great information, really high level overview. And a few questions have come through, so we will begin the Q&A session. And again, for our participants that are on, we have well over 100 with us. Again, please feel free to add your questions to the Q&A box, but I will begin because we have quite a few. First, just summarizing, a few questions have come through and also in the chat box saying, do you feel with programs like RISE and having adult protection services, more older adults would feel more comfortable in coming forward so we could actually get a true scale of what is happening with elder abuse, mistreatment in Canada and in Ontario specifically?
Could you just repeat the first part of the question as it related to APS?
Sorry, so the question was, would more older adults come forward if we had programs such as having older adult protection services and RISE as the model for them to be able to come forward?
Yeah, well, I mean, I don't want to get us into sort of a whole debate about adult protective services, because certainly the adult protective service system in the U.S. has its strengths, but it certainly has its limitations. I don't know that I don't know that one of its strengths specifically would be that it motivates older adults to come forward to seek help. We know that the vast majority of older adults do not come forward. With that said, I mean, one of the things that we tried to consider with RISE is that it's actually housed outside of APS. Like it's housed within a community-based organization, and we did that intentionally. With the thinking that may foster engagement. As I said before, a lot of older adults, for good reason, have reluctance to engage with formal systems. I think that certainly having some like an established kind of program that exists, a major advantage to that is that it forces a higher level of awareness. Like right now, without having something, it's like people don't really know who to call. There's, I mean, I shouldn't say that because a lot of people do know who to call, but I mean, the senior safety line and so forth are wonderful and doing great work. But I think still, like, more awareness could be there. And I think having some kind of established kind of program almost forces that into the culture. It leads, for example, to more and more training with professionals who work with older adults. It leads to more awareness for family members and concerned others who happen to be around older adults. And it just kind of raises the awareness. So hopefully it will help normalize and sort of socialize the issue into our kind of awareness and motivate older adults to come forward. And certainly we're setting up RISE. We're trying to be very sensitive to kind of set it up in a way that helps people come forward, knowing that it's really, really difficult.
Definitely. And that leads in perfect to the next question. So when will the program be ready in Toronto for people to utilize?
Great question. So as I mentioned before, we're currently hiring, and I don't know specifically, but if I had to kind of guess, it would sort of be in a few months.
Wonderful. And again, great segue for the next question. A few people have been asking, could you just go high level over the roles again that you're looking for, and maybe just some,
Sure.
top 5 qualifications that some of the candidates would need to possess to apply?
Yeah, absolutely. So the supervisor role, which the posting actually has expired, but anyways, that role, if it happened to open up again, basically we're looking for somebody who would be running the day-to-day operations. So certainly they would be supervising the 2 advocates, and sort of like the kind of clinical aspects that come along with that, but also playing like a really important role in helping to establish partnerships and collaborations with other agencies in the community. One of our, I think, biggest sort of considerations here is developing strong relationships with others in the community, both in terms of establishing, like a referral kind of system, but also in terms of working with other groups when it comes to casework, and supporting cases. So that's sort of the supervisor role, and then the advocate role is really, so there's 2 positions, is really these are the sort of direct practice kind of practitioner positions who are working directly with cases and implementing the intervention.
Thank you. And another question has just come through saying, sorry, just when RISE is actually launched, where will we find out about this and be able to know that it's live and ready to go?
Well, we will do our best to communicate that through our networks, and certainly in partnership with Elder Abuse Prevention Ontario, through their networks. So hopefully word gets out, we'll have a website, and you can certainly feel free to reach out to me directly, but that's the plan.
Excellent. Someone's asked, do you envision this as a federally driven or a provincial initiative? And will it be a long-term program?
Yeah, that's a great question. I definitely envision this as a long-term program. It's starting out as this 3-year project, but it is, assuming that it works well, it will require a home outside of our faculty, if that makes sense, and with a more sustainable sort of financial model behind it. And whether it makes sense to be provincially or federally driven, that's a really good question. And I don't have a good answer to that at the moment. Certainly for now, I'd have to know more about how these things are different across jurisdictions and provinces, and how these, there's a lot of things to think about there. It's a really, really, really good question.
Wonderful, thank you. And again, another just comment saying many outreach teams are already doing this work on the fly and are so looking forward and are going to be appreciative with a more concrete structure like RISE. And so they are anxiously waiting for it to be launched and released. Another question just came through. Yes, of course, definitely. We know the great work that's happening every day with all our community partners.
Absolutely. Yeah.
And Dr. Burns, can you speak to the success of this model when working with clients with cognitive impairments such as Alzheimer's or dementia? And do you have any data on this?
Yeah, so those cases would have been included in the analyses that I presented earlier. So, that does represent a substantial proportion of the cases that we've worked with in Maine. And in those cases, the advocate often is working with the caregiver as well as working with the older adult, but often there's an emphasis on working with the caregiver or the third party sort of decision maker. So, we recognize that's an important part of the population.
Of course, excellent. And just a comment came through from the Canadian National Prevention of Elder Abuse saying they will be more than happy to share updates about RISE on their website, newsletters, whenever you're ready to have them. So,
that's great. Well, I appreciate, and a shout out to the NPAA. I'm obviously involved with them too, and they're doing wonderful work, and so I appreciate the comments. Thank you.
Perfect. And one last question just before we wrap up. As you'd mentioned before that 6%, which is still a very low statistic of people that are referred to RISE, do decline or drop out. Could you give some insight as to why you think that is?
And often when I do presentations, I do it alongside our supervisor or operations director, and this is sometimes when I would refer to them, but I think I think it comes down to all of those reasons. There was a slide there where we kind of went through some of the reasons why people are reluctant to engage with services, and there's still a lot of stigma attached to kind of addressing this issue directly. A lot of the time we do hear that older adults are worried about what will happen to this person in my life. There's almost sometimes more concern about them than about themselves. There's certainly a concern about, does this mean I'm going to be placed in a nursing home or something? So there's all sorts of reasons, it happens.
Of course. I think people are just concerned even though it's still a low number, but they don't want those people to sort of fall through and not receive care they may need. Of course.
Agreed.
Yeah. And David, again, a few more, just more quick questions coming through about
sure, yeah.
the training model of RISE and how it'll be offered. And a few people are saying would community health centers would be a great place to provide and offer this. So your thoughts on sort of the rollout of the training, train the trainer program. So looking for your thoughts there, please.
Yeah, sure. Our thinking for this particular project, one is that for the training, there's going to be an experiential training aspect in which the supervisor and the advocates are actually going to go to Maine and spend a couple of weeks there and shadow their counterparts. So there's that kind of experiential form of training. And then here, they do receive training on each of those core components. So finding local experts in, for example, motivational interviewing, restorative justice, teaming, sport decision making, who can provide that training to them. We've also developed training materials for WISE that, for example, that involve case scenarios and sort of case analysis, that kind of stuff. So that's the approach.
Excellent. Perfect. Thank you. Thank you so much. And those are all the questions for now. And again, on behalf of the entire staff and team at Elder Abuse Prevention Ontario, all our delegates who are on the call webinar today with great comments, great feedback. I know you may not be able to see the chat box, but huge thank yous. Thank you for the continued work. Thank you for being the advocate. So just a lot of heartfelt, great wishes to all the work you're doing, Dr. Burns. And as always, thank you for being our speaker, keynote clothing speaker today. And we really appreciate your time, your insight, your knowledge, and your wisdom. Thank you so much.
That's very kind, and it's very much reciprocal. Thank you, and thank you to Elder Abuse Prevention Ontario. I really appreciate our partnership and your invitation.
Wonderful, thank you. Everyone enjoy the last closing remarks at the conference, and we thank you so much again. Have a nice afternoon, everyone. Bye-bye.